Good.
Welcome, everyone. How are you today? We're ready for our next podcast, which is show 13, all about breast lift and augmentation. I'm Dr. Sal Pacella from La Jolla in San Diego. My Instagram handle is at San Diego Plastic Surgeon. I'm joined by two incredibly talented surgeons, Dr. Sam Jejurikar from Dallas, Texas. His Instagram handle is at Sam Jejurikar, and Dr. Sam Rhee from Paramus, New Jersey, whose Instagram handle is at Bergen Cosmetic. East Coast. You got to do East Coast.
Oh, that's okay. Okay.
And then Samir, you do South.
Oh, that's a thing. Okay.
Yeah.
Okay.
Yeah. You know, it's all the kids are doing it. You gotta get with the program, homie.
No,
all right.
I always learn from you. Thank
you. All right. Well, so this show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking medical advice because of something in this show. Well, gentlemen, I'm going to hand it over now to Dr. Jejurikar from Dallas, Texas, and we're going to talk about breast lift and augmentation. Everything is bigger in Texas, is it not?
Not always, and that's what we're going to talk about today. Just as an intro, I think the term "mommy makeover" is one that we all hear and patients hear all the time, and it's sort of a grab bag term. You know, when you have children, it's the best thing that ever happened to your life, but probably the worst thing to ever happen to a woman's body. And so breast augmentation with lift is probably one of the 5 most common operations in my practice. Gentlemen, do you guys have the same experience with this? Like, it's just something that you see every day, you know, women coming in after children looking for more, for these sorts of procedures?
Absolutely. We have a little saying in our practice, children, they fulfill all our dreams, but ruin our bodies. You know, it's true.
I actually disagree with the first part of it, but anyway, yeah. But I definitely agree with the second part. Yeah.
And, I think, what I see here in San Diego and Southern California is there's a tremendous amount of destruction to the breast after breastfeeding. And there's a whole new layer of this, which is patients who have had previous breast augmentations. A good population of Southern California has breast implants. And unfortunately, fortunately, the breast implant stays usually in position, but the entire breast around it after pregnancy and breastfeeding doesn't play by those same rules. So that's a common issue I see in my practice.
Yeah, I would say as part of mommy makeovers, that's one of the biggest parts is rejuvenation of the breast shape, breast volume. That's a big one.
Right.
And Dr. Pacella, I'm glad you brought up that experience you're having in San Diego with secondary breast surgery. It just gave me an idea for a topic for another show, because that's something we see all the time in Dallas. It's not the case we'll show today, but it is a very common thing we'll see in Dallas as well as San Diego, and I'm sure in Paramus too. You see that,
right? And it's and there's a regional and time aspect to this too. I tend to see a lot of this kind of around the late part of winter or the early spring. Your patients are getting ready to go to the beach for the summer. They're hitting the Jersey Shore and all over the East Coast and heading down to Florida or the Gulf Coast, for the summer. And this is something that I really see uptick around February, March.
And so one of the things I want to ask you, a theme that we have had in previous shows for anyone that's listened to our podcast before, is we always talk about our Michigan training and how, we felt so prepared to handle a lot of cases that come our way, whether it's rhinoplasty, complex reconstructive cases. Dr. Rhee, when did you learn how to do a breast augmentation with lift? When did you do your first breast augpexy?
Not at Michigan. Not at Michigan. I will say, I don't know if you remember, but I think I asked you while you were doing your aesthetic fellowship at Meath. I was picking your brains while you were doing it, and I was asking you what your experience was there, because that was just not something we did very frequently in Ann Arbor.
Yeah, I agree. I really, this is an operation after our training in Michigan that I felt like I needed quite a bit more experience and quite a bit more strategy on how to make a good operation. And I did 2 cosmetic fellowships, one in Marina Del Rey with Dr. Grant Stevens, and the other with Dr. Nahai and Dr. Codner in Atlanta. And I would say that my education in breast lift and augmentation really, took off with those 2 fellowships. I felt like I had a good set of skills, a good toolkit for this operation, which quite honestly is still evolving today. I think, this is an area of plastic surgery where every single patient is different. The tissue components are different. The structure of the breast is exceptionally different in everybody. And we need a different set of tools for every patient.
And with that, I think, because there are a lot of things to discuss, let's go to the picture of the patient I want to discuss today. Is this in presentation mode when you look at this?
Sludge. Yeah, there you go.
Perfect. Okay. Well, and this is a lady who I just saw in my office. She's 3 or 4 months out in the post-op results we're going to talk, and that's why this case came to mind. But she's had children. She breastfed her children. Subsequent to that time, after having gone through multiple pregnancies, she's now lost a lot of weight. She wants her breasts fuller. She wants her breasts rounder. She wants more volume. How are you going to describe what you're going to do to this patient, and what do you see here? Dr. Pacella, tell us how you'd handle this in San Diego.
Well, so when I look at a patient like this, very similar to our patient population here in San Diego, clearly a very fit woman, a very athletic, a very in shape gal, but the breasts are not quite at the position that the rest of her body is in. Obviously, there's a laxity of tissue, there's a laxity of tremendous breast support, and I think not only a challenge is creating shape, but creating long-term tissue support to this gal. And quite honestly, this is an area that I struggle with a little bit in cosmetic surgery as to who I'm going to need to put additional tissue support into. What I mean by that is, inherently when we put an implant in a patient, we expect that implant to stay where we put it with some degree of a little bit of shifting with gravity and time. In somebody who has a breast appearance like this, where there's clearly stria or stretch marks, or the tissue is very thin, we also see this in patients with massive weight loss. There is inherently a lack of architecture to the breast. And oftentimes, if we put a big, heavy, thick implant in that patient, it's going to drop down over time. So to me, when I see a patient like this, a lot of the discussion is on additional extra tissue support.
Okay, and what
do I use for that?
Yeah, what do you use for that,
so,
and
right.
how do you make that determination based off of the implant size that you're going to? If you're putting in a small implant, are you going to use internal scaffolding? Are you going to do it with only a big implant? How do you do that?
Yeah, so good question. So I think with in patients that want a larger appearance, and many times, I would say on average, patients like this that come into my office in San Diego probably want on average a more athletic appearance, probably a small C cup, and perhaps an implant in the 275 to 350 range. That's somebody that I probably would not suggest tissue support in. Somebody who wants to be much larger in the large C or small D range, where I'm probably in the 450 to 500 range, that's somebody who I'm going to probably suggest using additional tissue support. Now, with regard to the products that are out there, I think a big workhorse that I use is something called Stratus. Stratus is essentially pigskin. It's the same material that we use in heart valves, prosthetic heart valves, and it's a big sheet of a device that you get off the shelf. And what that is used for is to create an internal bra or an internal scaffold to help support the breast long term. There are certainly other products on the market made of some synthetic materials. There's a list of products all throughout, on the shelf you can use for that.
Okay. And Dr. Rhee, what are your thoughts on what Dr. Pacella said, and what would you tell this patient?
I'm sure you'll talk more about the specific techniques and what you do, so I'll let that go for when you what comes up next. But what I would want to say about this particular patient is what you said before. She's thin, she looks fit. This is a patient where she probably comes in and says, "I don't like my saggy breasts." And this is one of those situations, like you said before, when you have pregnancy, when you have children, you can't out eat or out exercise yourself into a better shape for your breasts in this situation. There's nothing she can do physically on her own that's going to make that better appearing for her. That's why this is a very gratifying procedure. Now, the issue really is I will have some patients say, okay, I just want to be bigger, so if you just put some implants in, then would that be enough? And once you start talking about lifts, you're basically talking about putting incisions on the breast. Mm-hmm. And that is sometimes a challenge to talk to patients about, depending on what their expectations are. So the first thing is always talking about incisions. And then the second thing is volume, what size or goal they would want to be. And those are the first two things I generally approach with patients with this.
So Dr. Pacella, let's say your patient in San Diego says, I don't want any scars on my breast. I just want you to put a really large implant in there. Will you do it?
I would send her to Dallas.
Where we would happily do it after having a conversation about why that's not the right thing to do. Exactly.
Thank God you're not sending her out to the East Coast. That's all I can say.
Yeah, I would say, coming from, growing up in the Northeast and training in the Midwest and in the South, I have a very conservative aesthetic, and, a big, massive 700cc implant in this patient is going to look terrible. And more importantly, I'm going to explain to the patient what I'm going to be setting her. If we did that, what I would be setting her up for long-term in life. If I did that without putting any sort of lift or any tissue support and did a 700cc implant, you see this belly button right here? It's probably about a year and a half before those implants are sitting right down here on top of the belly button. And so I would do my best to convince her that, this is, you can't choose. Sometimes as a patient, you can't just pick and choose the operation that's best for you. You got to do it with the surgeon's counsel.
That's right. And, and it goes back to very basic lessons in physics. There's an unyielding force on the breast, which is gravity, and the heavier weight that's in the breast, the more things are going to stretch out over time. And so you're exactly right. What I'll say is I totally agree with everything you gentlemen have said. When I look at a patient like this, I'm kind of thinking about three things. I'm thinking about the support, just like Dr. Pacella talked about. I use a different product. I use more of a synthetic off-the-shelf product than Dr. Pacella does, but same general principle. It's nice for creating an internal bra to help prevent an implant from dropping. I think about the volume, and that leads to a conversation with the patient about what size they want to be. In this particular case, this patient wanted to have fullness and roundness, but nothing over the top. And then the most important thing, which is why this is different than a traditional breast augmentation for the purposes of what we're talking about, is how much droopiness they have. Patients oftentimes recognize that their breasts have changed, but they don't necessarily understand that it's not just the fact that they've lost volume and their breasts are smaller, that their entire soft tissue envelope has stretched out. And if you think about it, this happens during pregnancy when the breast tissue grows in size and swells and the skin stretches with it. Once pregnancy is over and breastfeeding is over and the breast tissue involutes, the skin doesn't go back and the skin is hanging. And so this generally represents the skin envelope for the breast tissue that somebody had during pregnancy or breastfeeding, what have you. And relative to the bottom portion of the breast sort of determines the amount of droopiness somebody has. And the way I generally think about it, and tell me if you guys disagree, the more significant the droopiness is, so grade 3 being the worst right here, the more significant the droopiness is, the more you got to do to the breast to make it better. And in general, the more unstable it is when you're putting in an implant. So if somebody has substantial sagging and they want a really big implant, I really try to talk them out of it, even if I'm adding support. If I'm unsuccessful, I let them know that the chances for needing a revision are pretty high. If they have reasonably small amount of droopiness and a reasonably small implant, my level of confidence and longevity of results goes way up. Do you guys have that same general thought process?
Yeah, I agree. And, the use of tissue support is a relatively recent phenomenon, I would say, in the last 15 to 20 years in plastic surgery. Years ago, the surgeons from the previous generation didn't have the luxury that we have today of utilizing these sort of synthetic or biologic tissue supports. And oftentimes what I've seen in patients who have surgery back, in the previous generation is we would rely upon the skin to support a heavy implant. And I think that's an error. The more we understand about how tissue support and gravity takes over, you can't use the parenchyma or the tissue of the breast or the skin to support a big, heavy implant.
Right.
We have two competing forces here. We're trying to tighten and minimize the breast envelope. And then we're also putting in an implant, which is increasing that volume within that breast envelope. And someone once said, I don't know if it was in Michigan or somewhere else, we're basically taking 10 pounds of potatoes and putting it into a 5-pound sack because we've just reduced the size of the sack and we're just increasing the number of potatoes that we're sticking in. So this is where experience comes into play, where you know what you can do in terms of how much lift you can get. As Sam in Texas said, it's a challenge when it gets very, very saggy. And then you're also trying to figure out what size implant you can put in safely, in addition to getting that tissue hiked up and repositioned.
Yeah,
that's funny. I remember that potato analogy slightly different, and I believe it was one of our co-residents was presenting something at a conference, and they described this particular resident as 10 pounds of BS in a 5-pound bag.
I have no recollection of this, but when we're off the podcast, I'll need to know more clearly.
Yes, I was thinking the same thing.
I agree with, again, everything you guys say. I think our thinking is very much aligned. When it comes to internal support, which I use a lot in my patients, I still want to make people realize that even though we're building an internal bra, it is not infallible. I think an internal bra is very good for helping to prevent the implant from dropping, but it doesn't add additional support to the skin. And so there's a different type of post-operative sagging we call a waterfall deformity, where essentially the implant can stay in place, but the tissue can still sag around it after one of these cases. And so even if you have scaffolding, it doesn't give you carte blanche to just pick any implant size you want and expect there not to be a complication.
Jersey Sam, around northern New Jersey, Manhattan, New York, obviously, CrossFit is a big issue, right? CrossFit is a big pastime.
For me, yes.
Yeah. And, you have a lot of athletic patients in that region. Mm-hmm. What Dr. Sam in Dallas was alluding to here is, you don't have carte blanche over things. So tell me about your strategy with athletic patients and the position of the implant, below the muscle, above the muscle, additional tissue support, et cetera.
Well, I would actually say that in La Jolla, you probably have more athletic patients than you have in Manhattan and in northern New Jersey. The weather's nicer over there. You guys are surfing and out on the beach all the time. We're at the shore, but only for the summer. And so I would say,
I'm talking about like the
yes,
the fitness models, the bodybuilders, the CrossFit. The first rule of CrossFit. You know what the first rule of CrossFit?
Always talk about CrossFit.
Always talk about CrossFit.
That is exactly right. It's a good thing this isn't my CrossFit podcast. Otherwise, you're right. So when you have a very athletic patient, the where you place the implant makes a big difference, especially if you're placing it under the muscle. You can get, when they're contracting their pecs, you can have issues associated with that. Sometimes you have to discuss with the patient, especially, in regards to the volume of the implant, how much breast tissue they have in addition, because if you have a very thin athletic patient, an implant's going to show more than someone who has more existing breast volume. So placement of the implant, size of implant, All of those things are probably even more important to talk about with the patient when they are very thin or very athletic.
Yeah. I think the animation deformity that Dr. Rhee is talking about is a very cool party trick for many people. Where essentially, where they flex their upper body, they can get their breasts to move around. And where you put the implant, in front of the muscle or behind the muscle, in my mind is a big decision making when I'm doing a straightforward breast augmentation. For most cases, unless a patient has a large amount of breast tissue, even if they're very athletic, I'll put it behind the muscle if I'm doing a simultaneous lift, because for your scaffolding, it really makes sense. Yeah, you need it. You need to have the implant behind the muscle. You sew the bottom edge of that scaffolding to the essentially to the rib cage, and the top edge you'll sew to the pec, and you can hold the implant in place. And so, there's no perfect solution for everybody, and an animation deformity where when they flex, their breasts will move. It's just one of the things that goes along with it. So, gentlemen, I'll go back and remind you of our case. How would you describe the lift you're going to perform on this patient? I'll give you two options. What we call a lollipop lift, which is an incision around the areola in a straight line coming down, or a more traditional lift, which is what we call a WISE pattern, which is going to be an anchor pattern. Dr. Rhee and Paramus, tell me, when you do a lift on this patient, how are you going to do it if you're using an implant?
I'm going straight to a WISE pattern. I mean, that's my preference. Maybe I'm more conservative, but I feel I need a significant amount of resection of the skin and repositioning, and that's what I would stick to.
What about you, Dr. Pacella? In La Jolla, what is your approach?
Well, so I think it really depends on the degree of lift here. And, if I'm just simply doing a lift of a couple centimeters, 2 centimeters max, and minimal tissue resection, I would probably do a lollipop. But I think the lollipop is very limited. Can you go back? Can you go to the next slide that shows yeah. So, my challenge in my hands here is this area right here medially. And oftentimes when we have an implant in and the tissue is stretching, I do tend to see a bit of bunching in this area, which is not really fantastic. I just think I have much more control with a WISE pattern. And, when patients complain about scars, or I shouldn't say complain, but when we sort of talk about scars, and I try to talk to them about this scar that goes underneath the breast, to be honest with you, most patients are pretty forgiving of this incision underneath the breast. They sort of tell me, well, it's hidden underneath the breast. I don't really see it. It's not too big of an issue. So I just think that, I prepare patients for the WISE pattern. And if I could get by with a vertical, that's great. But, going into the operation, it's usually a consent, an implied consent for a WISE pattern.
I agree entirely with what Dr. Pacella said and Dr. Rhee. I try to do a circumvertical and or a lollipop, and 95% of the time end up adding at least a small T across the bottom, so you can control the bunching of the skin that happens along this bottom portion.
Now, Sam, can I ask you a question here?
Yeah.
Both
Wait,
of you
which
guys.
Sam? Okay.
Texas Sam, and then Jersey Sam after. All right, I'm a patient. Well, doc, I don't understand. You got all this extra tissue here, and my nipples are round. Can't you just do this round incision and tighten everything up through one circle like this, right in the middle?
Yeah. And I have tried that. It's called the Benelli mastopexy for our viewers, and a lot of people actually come in asking it by name. And so it makes sense, at least in name, at least theoretically, that you should be able to bunch all your skin towards the central portion to get rid of the extra skin and slide the areola up. The problem is when you do that, you're going from one moment in time to the other when you're done with surgery, but you don't change the properties of the skin. So when you do that type of operation, invariably, unless you're doing more than about a centimeter of lift, what you'll end up seeing over time is, number one, the breast gets this flat pancakey look because the tissue sort of relaxes and the lower portion of the breast will expand, making people look like they need to get a revision breast lift. And as that happens, the areola can stretch and spread over time as well. So you get this jagged, poorly scarred areola. And so I've done many revisions on that case, almost none of which I was the primary surgeon for. It's just not a great operation. It's a very underpowered operation in most cases.
I agree with Sam 100%. I tried those. I abandoned it a long time ago. Unless you have a tiny amount of lift you need to achieve, you end up chasing yourself afterwards, and the results are just not very good.
Yeah, and I agree. And where I see that fairly limited is what you describe as the waterfall deformity here. So, looking at that fourth dimension, time, right? where that waterfall deformity occurs is right at the bottom here. And I am usually fairly aggressive in removing this tissue here because I don't want to see that waterfall deformity long time. And with the Benelli mastopexy, it's very difficult to do that. With a WISE pattern, it's fairly easy to do that. So it's just a limitation of the technique for sure. Before
I get to the post-operative results, two more questions. One, what order do you do the surgery? Do you put in your implant first and then do your lift, or do you do your lift first and put in your implant? And two, as you're talking implant selection, what things are you taking in mind? Is there a certain type of profile you favor, a certain type of implant you favor, a certain size you favor? What's your general approach? Either one of you gentlemen can start.
I'll start. I usually will I'll do the aug part first, but I will put the spacer in, and I'll leave the spacer in while I do all of my skin stuff. And then once or tissue envelope stuff. And then once I'm happy with that, that's when I take the spacer out and I put the final implant in.
Yeah, I same way. I mean, early on in my career, I would do the skin resection first and then choose the implant accordingly. And a few times I found myself sweating a little bit during the operation. How am I going to get this closed if I use a particular size of implant? So I've kind of backed off now, and I do the implant section first. I try to preserve as much of that pocket and tissue coverage as I can. I'll use a spacer or a sizer temporarily, sew in my device, sew in my tissue support, make sure the breast mound is as perfect as I can get it, and then do my soft tissue work around it. And then simply before I close everything, I'll put in the permanent implants. And the main reason I don't put the implants and then start working on the breast is just for infection risk. I want to put the final implant in as close to the end of the case as I can.
Okay. And then what do you tell your patients preoperatively about scarring? Like what do you do? Like what measures do you guys take in your practice to help control scarring, and over what period of time?
Go ahead,
yeah. So, we use a lot of, I think, the first step in scarring is what we talked about a week or two ago in our podcast, which is the type of suture we use. I think that has a critical effect on the appearance of scarring. So I really want to minimize knots along the incision. So I'll use a monofilament suture on the day of surgery. I'll try to minimize the total amount of knots, use some locking sutures or barb sutures. But after the fact, keeping the incision clean, obviously doing general wound care is important. And then once the incision is healed, I tend to use a lot of silicone ointments. I like ointments. They're a little easier to put on than silicone tape. If a patient really wants to use tape, I'm certainly amenable to that. I think silicone is really a key factor in scar appearance.
I agree with Sal. Meticulous closure is important for sure. I like barb sutures for my closures. And some kind of, you alluded to the time afterwards, and yes, you have to follow these patients in terms of their incision healing and their appearance for a long time. And some kind of silicone is what I use too, either strips or topical. But I'm a big fan of that too.
Yeah. So I do things very similar to you guys. And the reason I asked that question about the order of implant versus mastopexy is I thought everybody did it the way you guys described, myself included. But it turns out there are some plastic surgeons still who will put in will do their lift first and then put in their implants. Generally, they're restricting themselves to smaller implants, lower profile implants, which for our listeners are implants that don't have as much roundness to them, just so that it doesn't put any additional tension on their closure, which I just don't really quite get that, but there are people that still do that. I almost entirely in my practice use silicone gummy barrel implants. I suspect you guys are the same way. Almost, and I noticed that you guys we all sort of gloss over that question now because it's not even a choice for most plastic surgeons, but still every now and then we do get patients that request saline. And then for scar care, I do much of the same things that you guys do in terms of closure. I do use silicone ointment. I also use some pulse dye laser and broadband light after surgery as well to try to accelerate the process. But I think we do things all very, very similarly. Post-operative results. And I'll admit these are not long-term follow-ups. These are about 4 months out because I just saw the patient in the office this week and I thought she'd be a good case for the podcast. I'll also confess that I did a tummy tuck on this patient as well. So her tummy looks a little bit different, but that is not the focus of this. For this patient, I did largely circumvertical or lollipop lift with just a small transverse extension in the fold here. But I think this illustrates Dr. Pacella's point pretty well. You barely even see the scar, when it crosses over. And some of this is a crease, but you don't really see the scarring all that much. It's a really well hidden location. It's a very forgiving place to put that incision. 4 months out, you still see some pinkness of the scar right here, and I think that's fairly typical, and that should continue to fade over the next few months. We used a relatively sensible size implant, and I can't remember the exact size. I want to say it's around 345 cc's. So for that reason, I did not use any sort of internal scaffolding, but it was part of our decision making. And in fact, she's already told me she wished she had gone a little bit bigger. And so had we done that, I would have used some scaffolding, and that's a comment I'm sure you guys have heard multiple times, many times. But your thoughts?
One question for you. Was this a high profile implant you used?
It was a moderate profile plus implant that we used.
Oh, interesting.
Yeah. I try not to use too many high profile implants simultaneously at the time of a breast lift. I find those generally a high profile implant for our listeners is a rounder type of implant that actually, when you do your closure around it, at least in my hands, can lead to a little bit more spreading of the scars. So I did not use that.
Well, I think it's obviously an excellent result. It's fantastic. She has some pretty significant tan lines, so she's obviously been outside and enjoying herself pretty quickly. So she obviously feels pretty happy about her results because she looks like she's been wearing a bikini and gone out and enjoyed herself. I would say the projection looks fantastic. The funny thing from a regional variation standpoint is I have a lot of patients in this range. I have very few that feel like they would want to have gone bigger. I do like the shape that you achieved with the lift around the implant. I think that's fantastic, and I can only imagine she's extremely happy with that. I assume you did everything in one shot, and how long afterwards do you allow them to resume sort of regular activity and sun exposure and all that sort of thing?
So, it's, I think, a phenomena that many plastic surgeons see is that there's this rush for patients to get surgery shortly before they're going on a vacation. And there is a tape that we'll actually recommend our patients use if they're going on a beach vacation that's impregnated with zinc oxide. So as a result, they can get in the sun a little bit faster than they might otherwise because they basically have this tape over their incisions that has zinc oxide all over it. So I'm not too worried about them getting darkening or hyperpigmentation of their scar. In terms of regular activity, if I had just done the breasts, I don't let them do any form of exercise for about 4 weeks post-operatively. At 4 weeks, I let them do light aerobic activity. 3 months before I let them do any heavy lifting with their upper body. Because I did it
3 months, you say?
Yeah, 3 months.
Wow.
Particularly if I'm using scaffolding, I have seen a couple of cases where there's been late disruption of the scaffolding from forcible contraction of the pec muscle. So I'm fairly conservative, but I let them do aerobic activity stuff at about 4 weeks. But with the tummy tuck, I don't let people do any sort of exercise till they're about 6 weeks. And so it was 6 weeks for her.
It's a great result.
Yeah.
Looks really natural, really full, nice.
Thanks, guys.
Yeah.
Well, good. Let's see. Get off. So we are at that time yet again. It just magically always gets to the 30-minute mark, and it's in a little bit past. Any final thoughts from either of you gentlemen?
I really love this operation in the sense that it really is one that patients can't achieve on any level by themselves. Only through what we do can they get to this point. The satisfaction rate is amazingly high, and it's one that's still a challenge. Like you said, there are so many different aspects to working with the patient goals, figuring out their volume, figuring out their shape, figuring out internal tissue support that is still being, we're still all learning. As much as we know about it, we're still learning more about it every day. And I just listening to you guys keep pushing and pushing and pushing. It's not that you guys are happy with what you've done. You guys have gotten to a certain level of expertise. But what I love about the podcast is you guys keep pushing to get more and better with these techniques, which is what I'm trying to do too.
Yeah. Well, gentlemen, let's call it a wrap. Thank you again. Everyone have a wonderful week, and can't wait to do it again.
Thanks again.
Take care.